Hello and welcome. In this section, we're going to be talking a little bit about how you go from having decided that you think it's the right thing to go forward with changing practice to actually making a plan for doing so, implementing that plan, and also evaluating that throughout the process. So this here, we're really talking about the application components of things. And we've already talked about step 9, but we're focusing in here on steps 10, 11, and 12. All right. So developing a plan. Now, there are a bunch of different types of approaches for doing this, how you might think about it. So when we're thinking about a different type of clinical problem, there might be different levels at which you can make a change. So you could be focusing on individual patients, or you might be looking at the relationships between patients and providers. You might be thinking about changing an organization, or it might be a community-based problem, or it might be a larger societal problem, less common in clinical context, but sometimes happens, especially if you're taking more of a public health focus, right? But there's also a lot of different things that you could potentially do to pursue a change. So you could do everything from putting out media to make a change, to creating a protocol, to doing some sort of policy change of various different sorts. And you can do that at all these different levels. So when you're thinking about the intervention or clinical intervention you want to pick, you're really thinking about what is a strategy that's going to be most useful in your context. All right. So when you're thinking about these questions, we've talked previously about stakeholders. Sometimes stakeholders we're typically talking about people who are going to help you with this process or be interested in this process that you're pursuing. Very often, one of your stakeholders is actually going to be the target of your intervention. But the potential people who you might target are actually kind of similar to what that list of potential stakeholders might be. So we're thinking about patients or nurses or public health workers or physicians or other clinicians or administrators of various sorts. So there's a whole range of different people who you might want to be the focus of what you're trying of the change that you're trying to make in a clinical context. Or, as is often the case, you're actually focusing on a subset of multiple potential groups. So when we're thinking about planning this out carefully, it's important to recognize a lot of interventions don't work. It's quite common in clinical contexts and public health contexts that we go forth and we try and make a change and it doesn't stick, or it doesn't work out the way that we thought it was going to. So what we know is that there has actually been a fair bit of research and evidence to try and figure out why do things work or not work. So what are the different factors that we think about in terms of determining that? And one of the models that's been encouraged over the last decade or so is called the REAIM model. And this is a model that's been based upon studying those interventions that don't work to try and identify factors that we can improve on. All right. So the first component to this is REACH, out of REAIM, okay? So REACH is the idea that your intervention, you want to reach as many people as possible with it. So very often we focus in on very intense interventions where we only reach a few people, all right? That might work better for those individual people, but we might be forgetting about lots of other people who don't get to access this service, all right? So the greater the reach is, the greater the impact we'll have, all right? Another is effectiveness. Very often we focus on what we call efficacy. Efficacy is how big of an impact something has in sort of ideal circumstances. Those are typically, research type contexts where everybody who's involved is really interested in something, where you're sort of working under very often ideal circumstances. Effectiveness is more of an idea of how well does this actually work in real world settings? When we actually try and do this in the complex clinical context, all right, does it actually work out and how big of an impact does it have? As I have already mentioned, very often our focus tends to be on these very highly efficacious interventions, ones where we sit down and spend tons of time with people. They're often expensive, very intensive. And we tend to not pay much attention to other interventions, which might not have as high of an efficacy, but may, in a real-world context, be more useful. All right. Another thing that we want to think about is adoption, right? So when you create an intervention, sometimes we create interventions that are very particular to a specific context, all right? And that's often good. You want your intervention to work in the place that you're doing it. But you also might keep in mind, how easy will it be or interesting would it be for another clinical unit or site to actually adopt the intervention that you've developed? Is it very particular to yours, or is it something that's more easily portable to other contexts? So if we're thinking about making change in larger healthcare systems, that ability of something to be adopted is important. And very often this involves considering what would be attractive to other organizations, all right? How could things be set up so it doesn't require certain types of specialized knowledge or expertise, right? That will increase adoption, all right? The next one is implementation. So very often when we're trying to understand why things work or don't, why something works in one context or not, part of the problems that occur are that people change how they do things. So they take an intervention and they change it around a lot. Now, of course, you're going to customize things for different contexts, but having that prevents our ability to see whether or not it's actually working, right? If you don't have consistency across interventions, right? So having very clear delivery methods, very clear procedures for doing things can actually improve our ability to effectively use these clinical interventions and make an evidence-based practice change that will actually stick and that we can actually study in a clear way. And if you roll out an intervention across a clinical site where many different units are doing it and they're all doing it differently, how are you actually going to be able to evaluate it to see whether it's being implemented properly if everybody's doing it differently? The final thing that you might want to consider that's been shown to make a big difference is how hard is it to maintain this intervention that you designed, right? So certain types of things take a lot of energy and are very expensive to keep them rolling year after year after year. And other things, you put them into place and they will just keep on maintaining themselves essentially with relatively little work. So this sounds a little abstract. So what I'm going to do is offer you an example here. And the example I want to talk about is type 2 diabetes management, all right? So I'm going to give you two different proposed interventions. The first is the red line, all right, that is talking about a interactive online education module about how to manage your diabetes, okay? So the patient goes and accesses this online. The other one is what we often think about as these highly efficacious and interventions that we tend to think of as being more useful, right? So that would be, for example, here, the blue line, which is in-person counseling, where you sit down and you work with them one-on-one, for example, for an hour to train them how to manage their diabetes. Well, this is somewhat of an old graph from when REAIM was first proposed. So put together in about it's 1999. So as I'll say, this has kind of shifted a little bit. But think about reach, for example, as a way of comparing these two interventions. Well, if you think about the interactive technology, well, you can reach a lot more people, right? One of the big problems with type 2 diabetes management is a lot of people don't get the support that they need to manage their diabetes. And that is a real healthcare problem that we're facing. Well, the nice thing about online resources at this point, most of the United States public can actually access online resources, not with the same ease, but it is something that is accessible to most people. Whereas this intensive in-person counseling is much harder to access, and very often people can't, and sometimes it isn't even covered. So we would expect that online service might be have a higher reach. Efficacy. Well, very often we might think about that one-on-one intervention as being more effective, and that is a reasonable assumption that counseling would be. But one of the nice things about this online approaches is that you can actually carefully design and tailor these interventions, sometimes even specify it to the particular characteristics of the person and the reading level or something like that, right? So it is theoretically possible that these online technologies might actually improve substantially in terms of efficacy, but that remains to be determined. Another is adoption, right? So I actually think that at this point, 1999, this was sort of a different scenario, but I actually think that when it comes to adoption, if you have a good online service that's been created, it's much easier to pass that on between different units or different clinical sites, right? So in this case, what appears to be a less useful approach, which is the online approach, might actually be better in these contexts. And then implementation. So one of the nice things about this online context is that everybody will get exactly the same information. There won't be information missing. So it's very consistent in terms of how people get things. Whereas in this in-person counseling, it might look very different and have widely different styles in terms of how people do that counseling. And then finally, maintenance is very different across these two interventions. So the online approach, basically you create the program. It's going to be expensive to create that program, but once you do it, the cost is really paying to keep it running, right? And that's, a few hundred to a few thousand, a few thousands of dollars to keep it running over time. Whereas maintenance for an in-person counseling session, you're talking about salaries, you're talking about maintaining sites, you're talking about the coordination and scheduling and all those different things. So it's actually really hard to keep those things running over time. So this is just an example of why REAIM might actually be useful for thinking about interventions, all right? Because if you actually analyze some of these things, what we normally think of as being the best approach, that in-person intensive counseling session, may not be the best approach. Now, it might be. I'm in no way saying that you should always use these light touch online programs to solve all our problems. There's certainly situations where the in-person counseling is the right way to go. But what I'm saying here is that thinking carefully about this will help you to maximize the likelihood that your intervention is going to work. So thinking about those different components, making sure that it reaches as many people as possible, that you can maintain it over time, considering those different factors is an important consideration when you're designing your approach. All right. Another approach that's really of interest is when we're thinking about intervention design is called diffusion of innovation theory. So diffusion of innovation is essentially an idea around the fact that when you have a new idea, it's going to be distributed over time, right? So you're going to have some people who are what we call the innovators. Those are people who do something before anybody else has, even before experts sometimes have heard of them, right? These are people sometimes who are trying things out that maybe they shouldn't even be trying out. Then you might have early adopters. These are people who take on a new innovation relatively fast, right? They're seeking out that information, and that represents about 13% of the population. Then we have the early majority, and these folks are people who are generally higher educated. They tend to once they learn that there's a new thing out there that seems to be working, they'll do it. Late majority is the people who tend to wait until something seems to be used by most people, but once it is, they're willing to adopt it. And then there's a category called laggards, and these are folks who typically do not want to make any changes, all right? So when you think about the population that you're working with, you can actually very often separate out your population based upon these diffusion of innovation curves. Now, when you're thinking about these different populations, you actually sometimes want to target your intervention to those different groups because you talk to them in different ways. Because the interests of an early adopter are going to look different than the interests of, say, late majority, where you might be focusing on showing them that there's ease of use, that you can actually do this effectively. Whereas the early adopters, you might be emphasizing more the novelty and the empirical evidence for this as being the better way of doing things, right? So this is another way to think about how the process of making change occurs, all right? So there is another thing that sort of comes out of this diffusion of innovation theory where they've actually studied how change occurs in various different contexts. And this is primarily focusing on how people make decisions around these changes. But it can also be thought of at a community organizational level as well, right? So here are 5 different factors that you might consider. The first is, can you demonstrate that the new approach has a relative advantage to the previous approach? Can you make that clear to people why they should do this? And that's a pretty logical thing that people want to know. Another is compatibility. So how compatible is this new approach to what has previously been done? When something seems very different and like a big shift, then people are more reluctant to take it on in terms of a new change. So your interest here is to think about how can you demonstrate that it could easily be slid into our current processes and procedures. Another thing is the complexity of this new approach. People get concerned when something seems really hard to do. So how can you communicate to people that this will be easy and make it simple for them to think about approaching this? Another one is trialability. And the idea here is, if someone's thinking about this new approach, can they imagine just trying it out easily? Or do they have to go to, 2-week-long trainings to actually be able to do something? Or can they just sit down in 5 minutes and try it out and see how much they like it and start integrating it, right? So thinking about those, how to make it easy for people to try it out is another way that you can improve people's likelihood of using this new innovation or new approach. And finally, observability is important. So to what extent can people see other people using something? So if somebody sees that everybody else is doing that, they're more likely to actually adopt a new approach. So having that be a visual thing where people can see that it's being promoted by others, that's popular, can actually be a useful way of actually improving the likelihood of an innovation being successful. All right. So see, these are some sort of strategic factors that we think about with how different interventions work, what different types of factors you might think about and the different approaches that you're taking. It's very theoretical, but it's actually kind of some helpful checklists for going through different factors that might help you to choose between different approaches. All right. So let's talk about how you might actually design an intervention. All right. So first off, when you're thinking about taking intervention and talking about it to the public, one of the things that you want to think about is, what is our ideas about how you're actually going to achieve your change? So you've thought about the different considerations. You've tried to pick out an intervention style or approach that might work in the context. You also want to think about, theoretically, how is that actually going to occur? What is the philosophical foundation of your program or approach? How are you going to go from, point A to point B? So here you're going to be describing what you're going to do, what are your strategies. You can describe what you're going to get out of that, right? So one example of this sort of theoretical model that's often used in healthcare contexts is the Lewin's change model, all right? So this is often used in healthcare context because very often what you're doing is you're taking a clinical procedure or approach that is not ideal or is outdated, and you're trying to unfreeze people's behaviors. People sort of are used to doing a certain way. So you want to create an environment. So the theory here is that you engage in certain activities to create an environment that makes people comfortable making that change or encourages and excites people about making that change. Then you have the change step. All right. So here we're trying to help support people in making that change and communicating with them and training them in that process. All right. And then finally, you want to solidify that change, and that's a refreeze step. So that's where you have a change. It seems like you've made it and you want to solidify it so that people don't backslide into doing things the old way, right? So here's, different accountability procedures, for example, auditing or other things like that. And there's different strategies you can use here. So this is a model that you can actually look at and use some of their approaches to think about, okay, how do we actually design this and communicate this? Now, the reason that you might use a theoretical model like this, is it's very easy. It's about a 3-step model. You can create a nice graphic where you can show somebody, and within 30 seconds, they understand what your intervention's doing. They understand the philosophical idea of this process of how you're making a change. All right. So that's what these theoretical change models are trying to do. All right. They're a simple visual way of saying, here's how we're going to get from point A to point B. All right. There's also what we call logic models. All right. Logic models are somewhat of a different idea. All right. Here is a strategic approach for actually planning out your procedure. All right. And these tend to be more complex. And there's a lot of different logic models out there. There's a Kellogg model, there's a Wisconsin model, there's proceed, there's, just a ton of mappets. There's a whole bunch of different ways of doing this. And all of them essentially are trying to do the same thing. They're saying, we're going to take a strategic approach where we're going to figure out how we do things at different stages. We're going to ask different questions to make sure that we've addressed all the considerations, that we understand the situation we're dealing with, that we know what things we need, what resources we need to do something, that we actually have a plan for implementing it, and that we actually make sure that that plan actually aligns with the goals that we're trying to accomplish, right? So this is what these logic models are. They tend to be more complex than that theoretical model that we talked about earlier, okay? This is just an example here, just to give you an idea of what it would look like. I'm not going to try and teach how do you actually use a logic model here, because that's actually a fairly complex process. But here in this model, which is called the Wisconsin model, just an example, you're thinking about a few different factors. First off, in that first box, you're thinking about the situation and priorities. In the situation element, you're listing out all the different things about your clinical situation that you need to think about and consider. Why is this a problem? What do we know about the clinical environment that we're dealing with that affect this type of problem? Then in the priorities element, you're thinking about, what are our institutional priorities? Why does this matter? What are our priorities with respect to high quality healthcare, right? What do we care about? Then we think about inputs, all right? So based upon this, we figure out, what do we need to invest to actually make this happen? What do we need to put into this process to have our program succeed? Then we have outputs, and the outputs are things like activities and people who participate in, or different groups that participate in doing this, all right? And those are things that you list out in those columns. And then outcomes, you can think about what we're trying to produce, right? So you can think about SMART objectives, for example. So what's short-term, medium-term, and long-term, what are we trying to get out of doing all of this, all right? And there's boxes at the bottom that also you would sort of gather information about, and that would be assumptions. So what assumptions are you making about different factors related to the environment that actually determine whether or not these things will work? So here you're checking to make sure that your assumptions are actually realistic. And secondly, external factors. What are different factors that are outside of your control that could potentially block your ability to move forward with this program, okay? So you want to identify those, because you're again, forewarned is forearmed, right? So you can think about what might be in your way going forward, and you can sort of plan around that or think about that before you try and do something. So as you can see from this overall model, if you actually do each of these steps, you actually have a pretty good idea of what you actually need to do to move from point A to point B. All right, it's a pretty complete process. It's also provided in a fairly intuitive way. Now, this isn't something that you could look at in 30 seconds and figure out, but you could look at this logic model once it's filled out and be able to communicate about it with somebody over 5 minutes, and they could have a pretty good idea of what you need to do. And these are very helpful communication tools for actually planning things out in a strategic way. And there's a lot of, there's available for each of these models, there are resources that are available to actually help you go through each step and make sure that your thinking is clear and precise, and that you've considered all the potential things that you would need and all the potential things that could prevent this from effectively working. All right. So this is sort of a second step to that planning phase that is actually really highly encouraged for actually improving your likelihood of actually succeeding at what you're trying to do. So you create this plan, you have your models and you have your logic model, and ultimately you're going to have to come forward to talk to people about what you're trying to do. You might want to communicate in this using different methods. So you could show people your models. You could, this could be a direct communication. This could be printed out or written media. You'll have to think carefully about how you want to promote this as you're going forward. When you do it, remember to think carefully about your audience. How will they understand you? Can you speak clearly in a way that it will connect with what they need to understand? You also want to show why the evidence supports what you're trying to do, right? So you've put on all that effort into making this be evidence-based. So you want to, in a clear and simple way, show why this is important, and often in small snippets, right? You can provide the why details to people who are really interested, but you want to clearly and simply show why this is actually important from a health perspective. You also want to sometimes customize it to the audience that you're working with, right? So different people from different backgrounds, patients, clinicians, etc., might need different types of resources. You might have different pamphlets, for example, or promotional materials for different groups. You also might really want to try out your communication plan by doing focus groups with different people. So you might want to write something up and run it past a bunch of people who have different perspectives or different backgrounds to make sure that it's working. So these are a few things to just consider here. So when it comes to implementation, which is step 11, implementation is a little hard to talk about because how you actually do something really varies depending on what you're trying to do, right? So I can't really offer you a one-size-fits-all implementation approach. But when you're thinking about things like, say you're doing a clinical intervention where you're teaching people to make a change, all right? So you might do things, just as example, you might do a training where you're doing just lecturing to people or providing that didactic sort of education. Or you might do some sort of interactive hands-on training where you're helping people do things. Or maybe what you're trying to do is you're just putting up posters. It's a media-based approach where you're just talking to people about what, reminding people you need to wash your hands in XYZ way or something like that, right? So that might be a media campaign that you use. Or another way is to identify people, opinion leaders, champions who will take your ideas and help talk to people that they know to promote what you're trying to do. Train the trainer models, another example of this. So there's lots of different ways that you can do this. You can be creative, and this requires sort of talking with your stakeholders and working with different people to think about what is the best way, given what we're trying to do, to actually make this happen. As you're doing this, as you're implementing, it's also important to actually really be keeping track of how this is working. So you want to have mechanisms for auditing whether people are actually engaging in this change. You need to know that. You need to actually have ways for them to give you feedback about how it's going, right? Is it working or is it not? And identifying if there's performance gaps, you need to identify it so you can improve your systems. And as you're doing this, again, just as when we talked about stakeholders and the complex politics of this, you want to be paying close attention to the social systems that you're dealing with, right? That stakeholder analysis that we talked about earlier is still relevant as you're talking about the procedures of going forward and keeping an eye on those considerations. All right. So in step 12, I'm going to talk a little bit about that evaluation component. So evaluation is something that we can't underestimate. When you're thinking about a program, in terms of overall being able to demonstrate that it's successful, if you haven't done a careful job developing your evaluation process from the start, not at the end, but from the start, your likelihood of being able to maintain that program over time dramatically decreases, even if it's a good program, right? So if you have a new clinical change, you implement it, and you wait until the end to actually test whether or not it's working, well, you can't show that there was a difference over time. You're not going to be able to say, before it was like this, health outcomes were like this, and after it was like this. Now, sometimes you can from clinical records, but for other things, maybe you can't, all right? So you need to be able to show a before and after sort of impact, okay? Not to be underestimated. The second thing is sort of a political element to this. If you can't describe something and somebody says to you, well, why should I keep investing hundreds of thousands of dollars in your program over time, and you can't show evaluation results to show that this made a big impact? Well, you're not going to be able to support your argument, right? So again, this is really crucial for that maintenance component and also improvement component to things, all right? So when it comes to evaluation, it's the actual process for evaluation and the thought process behind evaluation is actually pretty similar to research. You're doing the same kind of process where you're trying to think about what are our questions based on what we're trying to do, what are the variables we're thinking about, and how do we study them to see whether there or not there's a change over time based upon this program, all right? Now, the difference here is really for evaluation, we're focused on the programmatic goals. We're not focused on having generalizable results or sort of focusing on a very specific element to an intervention. We're trying to think about, for our clinical practice, is this working or not? So we tend to think more broadly when we think about evaluation. And very often these evaluations look at a wide range of different activities. So it tends to be a little bit broader. But the techniques and approaches and thought processes are very similar to research in that, in terms of what we actually do. So when we think about what we're studying and we think about that before-after element, there's a lot of things that you might want to consider. So everything from medical records, the different indicators that we're looking at, medical records, tests, observations, attendance at workshops, all these different things that are involved in your program that you're developing that you want to think about and consider. And that's going to vary depending on your program. But these are just some things, examples of things you might consider to gather information about what's going on with your clinical project. All right. Okay. So when you sort of go through the steps of doing this, again, it looks very similar to evidence-based practice. Evaluation looks very similar to a research process. So you're identifying the variables, which we just talked about. You're thinking about what are our methods, how will we actually collect that data over time. You're thinking about how you get enough information from baseline and follow-up to actually be able to show whether or not you're having an impact. You think about design, how you would actually collect that data. So some things you might already be collecting, or some things might naturally be collected, but other things you'll actually have to deliberately go out and collect that data. And sometimes that involves surveys or other things that you need to work on. And based upon that, you may actually need people to be engaged in that, training people to actually collect that data. Then you go forth, and as you're going through this, you're collecting, and again, maybe that's beforehand and afterwards. And as you're doing this, remember, you're not just collecting data, you're also going to be looking at it throughout the process. Again, this is sometimes a little different than research, where maybe you're waiting till the end of the study's done and then you analyze the data. Here, very often, you're using that data as you get it to actually give feedback to the people you're working with about how well it's going, all right? And you're using that data to find those gaps, find those problems, and actually improve those processes. And sometimes, as you're doing this, you may actually find gaps or problems that actually will require going back into the evidence-based practice process. And again, remembering that this is a continual improvement process, right? So this is essentially, evaluation is really a tool for us to actually take that empirical evidence-based view towards our programs and making sure that they're actually working. Now, one final thing that I want to talk about here when we're thinking about evidence-based practice is that evidence-based practice is not just a process, and the application of it is not just these processes here that happen at an individual level with specific projects. It's also a bigger systemic sort of question, right? So how do we create a culture that actually supports evidence-based practice? I've talked to many different students who work in very different settings, some of which are very enthusiastic about evidence-based practice, and some of which are not as encouraging and make it very difficult for clinicians to actually engage in those processes. And at a larger level, it's really important for us to advocate and promote that culture and environment that actually encourages us to push forward with this. And make it something part of what we do. So there's a range of different things, thinking about recognizing and rewarding people when they engage in this and pursue it, both in leadership and also engaging in these changes. You can think about ensuring that people have resources and that there's governance processes for doing this. This needs to be a part of performance expectations so that we think about those systemic ways of encouraging this, right? And actually recognizing and supporting this. And we also want to think about our larger vision and mission and sort of strategic plan for an institution and our philosophy about how we care about our patients and providing healthcare. And between thinking about these different factors, we can really consider how we can actually change our systems to support an environment that encourages evidence-based practice in the context in which we're working. All right. So these are just some ideas for you. Again, the application of evidence-based practice is kind of an interesting process. As we've talked about, it's not just the evidence, it's also the feasibility elements, the practicalities of doing this, the plans and processes, and the real politics of thinking about shifting a healthcare organization, which is quite complex. And what we tried to do is sort of talk about a bunch of different methods and talked about sort of the ways that you can actually use these tools to systematically and strategically think about your ideas so that you maximize the likelihood that you'll be successful. So I hope that was helpful. I have found a lot of these processes to be helpful. So good luck. It's really important to be doing this. We know that there's many ways in which healthcare can be improved. So no shortage of opportunities to be an advocate for evidence-based practice and change. So again, thank you very much for listening and take care, everyone.